everyone, and welcome to a new session of clinical pharmacology and drug therapy. Today we are going to speak about glaucoma. I am Dr. Khalid Hassan, a professor of clinical pharmacology and drug therapy. The definition of glaucoma may be defined as increased intraocular pressure, and this will lead to the optic neuropathy, and this was associated with the loss of vision, loss of visual sensitivity, and loss of visual field, and this also will lead to the irreversible damage to the optic nerve. So we need to focus on the consequences of the glaucoma if left untreated. You can see here loss of visual field and damage to the nerves, loss of visual field again, retinal cell death. So we have several consequences regarding the glaucoma. Glaucoma epidemiology and prevalence to consider like the second leading cause of blindness worldwide, and glaucoma causes irreversible blindness, and this is important for us to know that if the blindness happens, this is a reversible maybe disease. Around 70 million people affected by the glaucoma in the United States, and this will lead, if the patient suffers from glaucoma, this will lead to the decreased quality of life, difficulties with the activities of daily living, and patient more likely to suffer from reported falls and more motor vehicle accident. Etiology of a glaucoma, etiology and pathophysiology. Glaucoma may be defined as increased intraocular pressure inside the eye. Intraocular pressure may be determined by the two components, the production, number one, and the outflow or drainage, number two, of the aqueous humor. So we have aqueous humor, and the aqueous humor we have increased production or decreased drainage. The normal, we need to remember also the normal intraocular pressure between 10 to 20 millimeter mercury. Aqueous humor flow through the trabecular meshwork and regulate intraocular pressure. So we have another component here called trabecular meshwork, could be the target therapy for medication later on. In glaucoma, there is a decrease or no outflow of aqueous humor. Moving to the pathophysiology, also we need to recognize two cases here. We have open angle glaucoma, we have closed angle glaucoma. Regarding open angle glaucoma, they said that this case considered like gradual disease, gradual increase in the intraocular pressure, and this will lead to the impaired drainage of aqueous humor. So we have increased intraocular pressure due to impaired drainage of aqueous humor through the trabecular meshwork. The elevation of intraocular pressure places mechanical stress on the optic nerve, and so we have stress on the optic nerve, and this will lead to the optic nerve damage and loss of visual field. For regarding closed angle glaucoma occur when the drainage angle between the iris and the cornea becomes blocked or narrow significantly. So we have the angle between the iris and the cornea, and this passage, this canal will be blocked, and normally this canal will open, allow the aqueous humor to pass. In this case, when we have blocked the contact between the iris and the cornea, this will lead to the closed angle glaucoma. The patient here will suffer from sudden dramatic increase in intraocular pressure. So you can see the sudden here. So sudden increase of intraocular pressure, and this will associate with the acute symptoms of intraocular pressure or acute symptoms of glaucoma. So this one will be acute. However, the open angle glaucoma considered like a chronic case. Okay, what is a glaucoma? This is the diagram here to simplify the image. As you can see here, we have two main factors maybe important in occurring or inducing glaucoma. Number one, increase production of aqueous humor. number one, or decreased drainage of aqueous humor. This will lead to the increased intraocular pressure. If left untreated, this will lead to the optic nerve damage, and this will lead to the vision loss. And as we stated in the beginning, this may cause blindness. Okay, how drugs act in glaucoma? When we prescribe medication, we aim for two goals. For patients suffering from glaucoma, patients suffering from increased intraocular pressure, we try to decrease intraocular pressure by prescribe medication or agent that able to decrease production of aqueous humor or increase drainage or outflow. So our medication will work on the production, decrease production, or increase drainage of aqueous humor. Okay, this is the simple diagram for the glaucoma. We have open angle glaucoma, then we have closed glaucoma. For the open angle glaucoma, you can see here the arrow here, the red arrow, the ciliary body here. The ciliary body produce the aqueous humor. Aqueous humor able to pass through the canal between the lens and the iris, and this is the iris here. Okay, able to pass, and drainage will occur through the trabecular meshwork, here, and maybe pass to the outer eye. Okay, this is the open angle glaucoma. So we don't have any problem between the iris and the lens. If you look on the closed angle glaucoma here, so you can see here the iris. This is the iris here. The iris is with the close contact with the lens, and this is a close contact. This is a close angle here. Does not allow the aqueous humor. You can see the arrow here. Then the aqueous humor will come back again, and the aqueous humor will accumulate in the anterior chamber, and this will lead to the increased intraocular pressure. Okay, again, before we start talking about medication or about therapy or treatment, we need to take patient medical history, and we need to take a drug history. If the patient take any medication, it's very important for us. We have a list of medication may increase intraocular pressure. A list of medication may cause glaucoma. Many medication can increase glaucoma. For example, here, this medication, if this medication increase risk of glaucoma, this is may worse the glaucoma if the patient already suffer from glaucoma, or may induce glaucoma. So we have two cases. If the patient suffer from glaucoma, this medication worsens the situation, or this medication may cause glaucoma, may induce glaucoma, and this depends on the type of glaucoma, and if the glaucoma adequately controlled or not. So this is very important to take in consideration. Is the patient adequately controlled his or her glaucoma? What type of glaucoma is open angle glaucoma or closed angle glaucoma? Okay, less of medication may induce or worsen the open angle glaucoma. We need to remember that we have closed angle glaucoma. So for example, we have steroid, three types, could be of ophthalmic steroid, systemic steroid, nasal steroid. All these type of steroid may cause, may aggravate, may worsen, or may induce open angle glaucoma. Phenoldopan belong to the calcium channel blockers, used for patients from hypertension, severe hypertension or hypertension crisis, and ophthalmic anticholinergic. Here we talk about, for example, trabecular. We talk about atropine. And this medication, if you apply this medication on the eye, the patient may suffer from induced or worsened open angle glaucoma. Succinylcholine, this medication used for general anesthesia. Vasodilation, if you speak about any medication may cause vasodilation, such as alpha blocker, for example, such as nifedipine. We have list of medication. Cimetidine here, cimetidine is considered like antihistamine H2 used for peptic ulcer disease. Okay, all these list of medication are repeated. This group of medication, this list here, may induce open angle glaucoma, may worsen open angle glaucoma. The first one, steroid, even ophthalmic, systemic or nasal, phenoldipan, ophthalmic anticholinergic, succinylcholine, vasodilator, and cimetidine. Regarding close angle glaucoma, we have list of medication. Number one, we have topical anticholinergic, topical sympathomimetic, systemic anticholinergic, tricyclic antidepressant, antihistamine, ipratropium, SSR, imabramine, venlafaxine, topiramate. This list of medication may induce or may worsen closed angle glaucoma. A little bit of explanation. Topical anticholinergic is already covered there. Could be trabecular, or could be atropine, for example, here when you apply it to the eye. Then we have topical sympathomimetic such as phenylephrine. Systemic anticholinergic, so we can speak about medications such as oxybutynin, tiotropium, and other medication. Tricyclic antidepressant here such as imabramine. Okay, so we have it here, tricyclic antidepressant. Antihistamine, especially we talk about first generation antihistamine such as dimenhydrinate. Okay, ipratropium, this medication considered like muscarinic receptor antagonist and used for asthma. This medication may cause or aggravate as a closed angle glaucoma. SSR stands for serotonin selective reuptake inhibitors such as fluoxetine, Prozac, brand name, imabramine, venlafaxine, topiramate, anti-epileptic medication. So we need to remember all these group of medication for patients suffer from open angle glaucoma or closed angle glaucoma. Okay, now we move to the apply medication. We need to understand the process of formation of aqueous humor in order to be able to use our medication. We start looking on what we have inside the eye. We have blood vessels, as you can see here. We have blood vessels, and we all know that in the blood vessels we have receptor. Okay, in the blood vessel we have receptor, and this receptor will be alpha 1 receptor and beta 2 receptor. So we know that in the blood vessels. Okay, then we have ciliary cells, ciliary epithelial. Then we have aqueous humor. Then we have the drainage. So you can see here we have the production. Then we have drainage here. Okay. So what we have, if you look what we have here, they try to remind us the first group of medication will affect this process. This image here will be prostaglandin. Prostaglandin BG stands for prostaglandin. Okay, prostaglandin, you can see the plus here mean stimulate. So prostaglandin stimulate the drainage of the aqueous humor through the uvosiclerar pathway, and in another effect will be the trabecular meshwork drainage. So with the number one, that mean the first group of medication, first line therapy for the medication for patients who are from glaucoma will be prostaglandin, first line therapy. So you can see the first line therapy. The question, what is the first line therapy? I will start thinking about prostaglandin analog. Okay, the first line therapy also will be a beta blocker. So beta blocker here, we try to understand what happened. Beta blocker, two things. Number one, if you stimulate beta receptor, the result will be increased production of aqueous humor. Okay, number one. If we stimulate beta 1, the result will be vasodilation and increase blood flow. Okay, increase blood flow, and this will increase aqueous humor secretion. So the beta receptor work on the eye in two mechanisms. Number one, increase direct effect by increasing aqueous humor. Number two, by induce vasodilation through the beta 2 effect, cause vasodilation, increase blood flow, and increase aqueous humor. Okay, what happened here? We prescribe beta blocker, so we tried to block beta here. So if you go back again, we tried to block beta, blocking beta here. So if you stimulate beta, we have the result. What happened if you block beta? If you block beta, the result will be the opposite. The production will be decreased. Number one. Number two, the blood flow will be decreased due to the vasoconstriction. Okay, so you can see here the decreased vasoconstriction and decreased blood flow. So this is the reason here for why beta blockers used as a first-line therapy for patients of glaucoma. If you need to understand more details about the effect of beta blockers on the eye, the effect of beta blocker and the blood vessels, because here we talk about blood vessels in this part here, I recommend you to review the lecture about adrenergic agonist, adrenergic antagonist. Okay, so moving to the next step. Again, I would like to repeat. Here we have prostaglandin as a first-line therapy, increase blood flow, increase drainage. Prostaglandin, the second line will be beta blocker, two mechanism. We explained it already. As you can see here, decrease production. Beta blocker and two mechanism, decrease production. Number three, we have alpha-2 agonist. Alpha-2 agonists also decrease production of aqueous humor. Alpha-2 agonists work on the GI protein and decrease cyclic AMP and decrease aqueous humor production. Okay, this is the third group of medication. Number one, prostaglandin. Number two, beta blocker. Number three, alpha-2 agonist. Okay, so sometimes we use combination treatment between the alpha-2 and carbonic anhydrase. So we use it as a combination therapy in one eye drops. So we can see it there, and we are going to present it in the next slide. Okay, then we have some medication considered like miotic. Here we talk about pilocarpine. Here we talk about neostigmine, for example. Okay. Okay, so we're done with the explanation. This is the most important image for us to learn and remember about the group of medication used for glaucoma. Number one, prostaglandin. Number two, beta blocker. Number three, we have carbonic anhydrase inhibitor. Number four, we have alpha-2 agonist. Number five, we have miotic. Regarding carbonic anhydrase inhibitor, CAIs, this enzyme, carbonic anhydrase, before we talk about inhibitor, this enzyme is an important enzyme for synthesis of aqueous humor. This enzyme facilitates the composition of water and carbonic acid to form the aqueous humor. Okay, so now we need to remember maybe four or five main groups that are important for the treatment of glaucoma. We have another one here. It's very rare and to use in the clinical practice. Number six, alpha agonist. It's very rare to use in the clinical practice. Okay. Role of autonomic nervous system on the intraocular pressure. We talk about parasympathetic here. If you parasympathetic, when you stimulate M3 receptor in the eye, and this will lead to the pupillary constriction, and this will lead to the decreased intraocular pressure. So this is one maybe pathway for parasympathetic. Parasympathetic agonist will be important. Sympathetic system, here we have pupillary dilation, such as, for example, phenylephrine. Okay, pupillary dilation stimulating alpha-1 receptor, and this will lead to the increased intraocular pressure. Okay, first group of medication. This is our topic here. This is the important one. Role of the parasympathetic system on intraocular pressure. We have first group of medication work directly on the cholinergic agonist, direct acting cholinergic agonist. That means when we have medication drug, when we speak about direct, that means bind to the receptor and activate the receptor. This is activate the receptor. This is the direct action here. So the medication bind to the receptor, activate the receptor. We have pilocarpine, we have carbacol. As you can see here, pilocarpine activate, stimulate M3 receptor. This will lead to the pupillary constriction and increase outflow. So nothing to do with the production, increase drainage, increase outflow, and this will lead to the decreased intraocular pressure. And if you prescribe this one to 100 patients, they found it's like this medication decrease intraocular pressure by 20 to 30%. This will be great result for the patient. So we have pilocarpine, and then we have carbacol. Pilocarpine mostly used in the closed angle glaucoma, and if you remember that in the beginning, closed angle glaucoma, CAG, considered like acute emergency case. We don't use it in the chronic. But pilocarpine may cause decreased vision in patients with cataract, so we don't recommend it to use it. Pilocarpine, we don't recommend it to use it in patients with uveitis and ocular inflammation. So we have some cautions, we have some precautions, we have some warning here for the patient, during use pilocarpine or carbacol. Okay, moving to the second group of medication. Okay, this medication work on the this medication work by inhibit the enzyme called acetylcholinesterase. Okay, we need to remind you we have acetylcholine, and this acetylcholine will be metabolized to the acetate and choline. Okay, by the intervention of enzyme called acetylcholinesterase. So our group of medication here, acetylcholinesterase inhibitor. We have, as you can see, we have visostigmine, ecothiophate, inhibit this enzyme. The result will be increased level of acetylcholine. So you can see here, by inhibit the acetylcholinesterase, this will lead to the accumulation of acetylcholine, prolonged action of acetylcholine, and activate muscarinic receptor. Activation of muscarinic receptor, speaking about the eye, the result will be pupillary constriction and increase outflow again. The second group of medication. Moving to the next group of medication, adrenergic agonist. Adrenergic agonist, we have selective, non-selective. We always prefer to use selective treatment for the human body. Selective treatment is preferred because it will be effective, will be less adverse effect. Non-selective, so non-selective agonist, non-selective adrenergic agonist. Here we know that we have epinephrine, but we know that epinephrine stimulate alpha-1, stimulate alpha-2, stimulate beta-2, stimulate beta-1, stimulate beta-3. So in this case, we don't recommend to use epinephrine on the eye because it's effect of all these receptors on the eye. Okay, so you can see here adverse effect of when you use epinephrine. We have the rest of medication. Then we have some eye drops similar to the epinephrine called dabivirin. Dabivirin is considered like prodrug. The adverse effect reaction when you use epinephrine and dabivirin to the patient will be local side effect like tearing, burning, blurred vision, macular edema, pigment deposits, conjunctival hyperemia, and keratopathy. Here, this is an important one, and they found it in some patients may suffer from headache, tachycardia, arrhythmia, tremor, anxiety, and increased blood pressure. So we don't recommend to use epinephrine for patients who suffer from hypertension, even it like eye drops. We don't recommend it to use it. Okay, keep talking about what we have here. For this reason here, non-selective epinephrine is not popular in the clinical use, because this medication may block the canal and prevent outflow, and this will be contraindication in patient with a closed angle glaucoma. So the epinephrine, phenylephrine like alpha-1 agonist, phenylephrine alpha-1 agonist, we don't recommend it because mydriasis close the canal, and this will consider like contraindicated in patient with the closed angle glaucoma. However, can we use alpha-2 agonists? Yes, alpha-2 selective agonist. This is a preferred medication. We have two medications, ibraclonidine and brimonidine, and this group of medication considered like second line treatment of glaucoma. So please remember, first line treatment will be prostaglandin and or beta blocker. Okay, how this medication work? You can see here again for non-selective, not used in glaucoma anymore. Okay, several underline here, not used in okay, alpha-2 agonist. This is an important one. Alpha-2 agonist. We have ibraclonidine, brimonidine, stimulate alpha receptor, working on the GI protein, and this will decrease cyclic AMP. Also, another effect will be decrease venous pressure, decrease epicyclar venous pressure. This will lead to the two effects. Number one, by decreasing cyclic AMP, this will lead to the decreased aqueous humor production. That's great, and increase outflow. Okay, so the question here, what is or are the mechanism of action of ibraclonidine on the eye? Ibraclonidine stimulate alpha-2 receptor. Two mechanisms. Number one, decreased cyclic AMP, lead to the decreased production of aqueous humor. Number two, decrease epicyclar venous pressure, lead to the increased outflow. So two main action. Number one, decreased production. Number two, increased flow of aqueous humor. So we need to remember here the ibraclonidine and brimonidine, and this one considered like second line therapy for patients from glaucoma. Okay, beta blocker. If you go back, I recommend you to review the adrenergic agonist, antagonist before you read this information here. For beta blockers, we have non-selective beta blocker. We have selective beta blocker, selective beta 1 blocker. Non-selective beta blocker example here, we have timolol, cartilol, we have levobendelol, we have brandolol. So all these medication, how this medication work. So in order to understand this one here, we need to go back and remember, okay, what happened there if you stimulate beta receptor. Okay, this will activate GS protein and increase cyclic AMP. So this is what we have in beta agonist. So what happened here? Our medication block beta. So we can go there and maybe remove this one here, blocking beta. This will lead to the decreased activation of GS. This will lead to the decreased cyclic AMP, and the result you can see it here. Okay, we have this group of medication, decreased cyclic AMP, and decreased cyclic AMP will decrease aqueous humor production. So we have the process here. It's very important to remember that. Okay, before we go further in the details, these beta receptor, beta blocker agents, we have timolol, cartilol, non-selective. Giving medication belong to the beta 1 receptor, beta 1 blocker used for glaucoma. We have betaxolol. Okay, we have betaxolol. Betaxolol available like eye drops, and this one also eye drops, the non-selective. Okay, in this slide here from Google image, you can see here we have some medication, some eye drops from timolol. You can see it. If you click on the timolol here, you can see the medication again. timolol. Here you can see the product timolol available as eye drops. If I move to the betaxolol, you can see the betaxolol also here available as eye drops. Also, these two medication, betaxolol and timolol, this medication used for treatment of glaucoma, and timolol betaxolol belong to the beta blocker. So the question here, which of the following medication belong to the beta blocker used for glaucoma? We have list of medication: betaxolol, timolol, cartulol. The question also in another way: which of these medication block beta 1 selectively and used for glaucoma? This will be betaxolol. Which of these medication block beta 1, beta 2 and used for glaucoma? We have timolol. So we need to remember which one selective, which one non-selective. And speaking about the effectiveness of this medication decrease intraocular pressure by 20 to 30%. Caution should be taken in patients, so for example, in patients from bradycardia, asthma, or COPD, heart failure. All these will be caution and sometimes contraindicated. So we have to be careful. We have to take maybe warn the patient about worsening symptoms of these cases here, to maybe to seek advance and help from the healthcare provider. Okay, so as you can see here, we don't recommend to use beta blocker in general. Here we talk about general advice and caution, warning. We don't recommend to use beta blocker in patients with diabetes because beta blocker masks symptoms of hypoglycemia. We don't recommend to use beta blocker in patients with thyrotoxicosis, mask symptoms of thyrotoxicosis. This is another case of contraindication. Timolol actively secreted and the breast milk and concentrated there, so we have to be careful in the during lactation period. What is a contraindication of beta blocker? We don't use it in cardiogenic shock, in patient with a heart failure, in patient with a heart block, in patient with a sinus bradycardia, or patient with asthma or COPD. So all these, this is speaking about general beta blocker, not on the eye drops. But this one should be all these should be taken in consideration when you prescribe beta blocker to your patient, even eye drops or nasal drops or like oral or injectable. Okay, moving to the next group of medication, we have carbonic anhydrase inhibitors. You know that we have the enzyme here. This enzyme responsible for synthesis of carbonic acid from the carbon dioxide and water with the carbonic anhydrase enzyme. So we have a carbonic anhydrase enzyme responsible for synthesis of carbonic acid, and this will lead to the formation of aqueous humor production. So carbonic anhydrase is responsible for aqueous humor production. What happened here if you inhibit this enzyme? We have a group of medication called carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor inhibit this enzyme. This will lead to the decreased carbonic acid, and the end result will be decreased aqueous humor reduction. We have two types of carbonic anhydrase available in the practice. Number one, we have oral carbonic anhydrase. We have topical eye drops topical eye drops from the like dorzolamide and brinzolamide. So available dorzolamide, brinzolamide eye drops. So you can see it here, eye drops, dorzolamide and brinzolamide. Okay, eye drops. What is brinzolamide and dorzolamide? It's like belong to the carbonic anhydrase inhibitor. Okay, so effectiveness decrease intraocular pressure by 25 to 40%. This medication used topically in the eye as alternative to the beta blocker. What that mean is like it's not first line therapy. This is not first line therapy. Okay, could be second line therapy, alternative. You can see the alternative here, carbonic anhydrase. What about oral? We have oral carbonic anhydrase. Yes, oral. We have oral. This one, consider if you prescribe it orally, last line treatment, because this medication may cause sulfa allergy. The chemical structure is sulfa for this medication. We don't recommend to use it for patients who suffer from sulfa allergy. We don't recommend to use this medication for patients who suffer from sickle cell disease. for patients suffer from hepatic disease or renal disease, patients suffer from diabetes, patients suffer from Addison disease. Addison disease means hypo or decreased function of adrenal cortex. So we have adrenal gland deficiency, hypodeficiency of adrenal cortex. So Addison disease, deficiency of activity of adrenal cortex. The opposite of Addison disease, we have Cushing syndrome, hypersecretion of hyperactivity of the adrenal cortex. So if the patients are from Addison disease, or repeated, we don't recommend, caution should be taken if the patients are from Addison disease to prescribe oral acetazolamide. Okay, so someone may ask, what is acetazolamide? Use it for what, for example? Okay, this image here shows the acetazolamide. As you can see here, acetazolamide. Also, this another one, tablets, available tablets, acetazolamide. And it's not considered like first-line therapy, as you mentioned. Acetazolamide oral, acetazolamide last-line therapy for and systemic cause more adverse effect. So we don't recommend to use oral tablet for the patients of glaucoma. And we have number one, we need to remember, highlight this: if you prescribe acetazolamide to the patient, there is a risk of sulfa allergy. We don't recommend it to use it or use it with caution in patients with the sickle cell disease, hepatic disease, renal disease, diabetes, or Addison disease. Okay, moving to the prostaglandin. Okay, prostaglandin, if you remember, consider like first-line therapy. Prostaglandin, first-line therapy. Okay, so we have 3 or 4 main medication: latanoprost, we have travoprost, bimatoprost, and tafloprost, with a different dosage here and different concentration. This medication, this group prostaglandin analog, that mean able to stimulate the prostaglandin, mimic the effect of prostaglandin. And this one, they said, this mainly affect the drainage of trabecular meshwork and the effect of the uvosiclar drainage, and the result will be enhanced outflow of aqueous humor. Very important. So prostaglandin, first of all, first-line therapy. Prostaglandin, first-line therapy. So prostaglandin, first-line therapy. Beta blocker, first-line therapy for the patients of from glaucoma. But they try to remind us we have 9 types of receptor in the body. 2 types available in the eye: F receptor and prostaglandin F or prostaglandin E. So prostaglandin F and E available on the eye, especially on the trabecular meshwork and the sclera. This is number one. Number two, what is the differences? What are the differences between these all these medication? We can prepare like a chart comparing between pharmacokinetic, pharmacodynamic of these medication. Okay, moving to the tafloprost or tafloprost here. The tafloprost present maybe offer some advantages. You can see the concentration here. So tafloprost presents something very important: the affinity to the prostaglandin receptor. And they said the tafloprost is more than 12 times higher affinity to the receptor, and this presents the more efficacy or more effectiveness. So which of the following prostaglandin consider like more higher affinity toward the prostaglandin receptor? We have tafloprost. Okay. Next we have a new medication, maybe not like yesterday, but could be during the 1 year, before 1 year. But you remember that when you speak about propranolol, when you speak about ibraclonidine, when you speak about the latanoprost, this medication in the market since maybe more than 50 years or sometimes 100 years ago. But this medication roughly new introduced to the market, Robressa. So the Robressa reduce intraocular pressure by 3 different mechanisms, 3 separate mode of action. So this is important things. Robressa, this medication, reduce intraocular pressure by 3 different mechanisms of action. Number 1, Robressa inhibit RUC. And RUC stands for Rho kinase enzyme. So number 1, inhibit RUC, and this enzyme available in the trabecular meshwork. When you inhibit RUC in the trabecular meshwork, this will lead to the increased outflow of the aqueous humor through the trabecular meshwork. Number one. Number two, this enzyme reduce venous pressure, venous blood pressure in the epiciclera. Number two. And number three, this medication inhibit NET. NET stands for norepinephrine transporter. So three mechanisms of action how the Robressa use or decrease intraocular pressure. Number one, inhibit RAC enzyme and the trabecular meshwork. Number two, reduce venous blood pressure and the epiciclera. And number three, inhibit norepinephrine transporter. Three main mechanisms. The question here, where is the location of the treatment and the guidelines? Are you going to prescribe it as a first medication? No, it's not first medication. Not first medication for the glaucoma. We don't want to prescribe it. You can see it here. It's considered like second line treatment. It's not first line treatment. Robressa, okay, is likely to be used for as second line treatment. You prescribe prostaglandin, you prescribe beta blocker, and this one is like could be contraindicated, could be allergy, could be some. If the patient not benefit from this medication, we can switch to another medication like Robressa. Okay, let me click on this link here to show you some literature review. Okay, this article published on the website, and so if I scroll down here for this article, only to show you what we have here, you can see the Robressa here for the medication. Robressa inhibit RAC, relaxed trabecular meshwork. Okay, inhibit the RAC and relaxing. Number two, inhibit norepinephrine transporter. Number three, lower epiciclera venous pressure. So this is the medication name and the NET, RAC, outflow. All these will be present here on the image. Okay, so the Robressa is like the brand name, Robressa brand name, and generic name will be Netarsodil, ophthalmic solution, once daily, eye drops, as you can see here, inhibit RAC, and targeting the trabecular meshwork and the aqueous, increase aqueous humor outflow. I'm looking on the website here. If I click on this website here, they make the image bigger, and you can see how this medication work for Robressa, three mechanisms of action. So you can read Robressa reduces intraocular pressure by three different mode of action. And again, for this one here, this chart here, they show us the baseline when the patient comes first to the clinic, and you can see the intraocular pressure. And then we have after 14 days after applying latanoprost, the maroon color. Then we have the dark blue, light blue for Robressa with different concentration. And what we have here, if you compare, for example, here they try to compare between the Robressa and latanoprost. For this graph here, you can see it's like they reduce the intraocular pressure and similar, and this may convince us, and this may conclude that latanoprost is more effective in lowering intraocular pressure comparing with the Robressa 0.01, 0.02, but this is very close to each other. For example, after 14 days, Robressa 19.8, 19.5, latanoprost 18.4. So very close to each other. And this one, if the patient does not benefit from latanoprost, we can switch to Robressa. But if the patient benefit from the latanoprost, we keep it on the latanoprost because they consider like cheap, number one, available, effective medication. The Robressa will be expensive medication. Okay, the question now for us, what is the therapeutic goal of glaucoma? Number one, preserve visual function. Number two, decrease intraocular pressure. Number three, prevent further optic nerve damage. Treatment option again for the open angle glaucoma, we have first line, initial and second line. Alternative, we go with the surgery sometimes or with the laser trabecular plasty. As you can see here, for the first line therapy, we have prostaglandin, beta blocker, Could be carbonic anhydrase, alpha blocker, initial therapy. So the first two will be initial therapy. If the patient does not benefit, we move to the anhydrase inhibitor and alpha blocker. Second line therapy, sympathomimetic and systemic carbonic anhydrase, alpha 2 agents also. Okay, if the patients are from acute closed angle glaucoma, what we can do here, we can, this one, remember that we have, this is what acute mean emergency case. We prescribe some medication IV such as mannitol, as osmotic agent, mannitol or glycerin. So we have mannitol and glycerin. We can use some topical medication such as alpha agonist, beta blocker, carbonic anhydrase, prostaglandin analog. We go to the pilocarpine to use it in the acute closed angle glaucoma, iridotomy as surgery options. This is the final and the curative maybe approach to the closed angle glaucoma. And the purpose of this attempt to rapid reduction in intraocular pressure, suppression of inflammation, reversal of angle closure, then preserve vision. Okay, so here we have some group of medication to remind you with. We talk about beta blocker first line therapy. We have betaxolol, timolol, for example here, prostaglandin, latanoprost, and bimatoprost, first line therapy. So first line therapy, two medication here we need to remember. Latanoprost pound here, latanoprost pound, this is another medication, latanoprost pound, you can see it here. And this is a medication considered like prodrug of latanoprost and will be metabolized. And when this medication metabolized, the result will be producing nitric oxide or donate nitric oxide. This provide dual mechanism by increasing aqueous humor, outflow of aqueous humor. Next we have second line brimonidine is like considered like topical carbonic anhydrase, well tolerated and effective in as a second line therapy. What about pilocarpine? Pilocarpine is considered like third line therapy. We use pilocarpine only for the acute closed angle glaucoma. Carbachol, dibivirine, topical anticholinergic, acetazolamide, considered like last option. Robressa, netarsodil, first approval ROC kinase inhibitors. We discussed that in details in previous slide. Moving to the anti-proliferative agents such as fluorouracil, mitomycin, and this considered like anti-cancer medications. This is a final option for the patients from glaucoma. Again, this slide here summarizes the approach for patients from closed angle glaucoma. And remind you, this is acute closed angle glaucoma, AACC. The patients are from high intraocular pressure and require rapid intervention, rapid reduction in intraocular pressure. Okay, iridotomy is the definitive treatment for producing the hole in the iris that permit aqueous humor to flow through directly from the posterior to the anterior chamber. So the iridotomy is the final maybe option, the definitive treatment for the glaucoma by producing a hole in the iris that allow aqueous humor to flow and move directly from posterior to the anterior. Drug therapy here, drug therapy of an acute attack typically would go the meiotic such as pilocarpine with some secretory inhibitors such as beta blocker, alpha agonist, carbonic anhydrase, prostaglandin. Osmotic, we can prescribe mannitol or glycerin. So the patient sometimes use cortisol to decrease inflammation. So we have list of medication. Number one, iridotomy as a maybe definitive treatment. Number two, pilocarpine. Then think about other agent. Osmotic such as mannitol, glycerin. We use cortisol to the eye to decrease inflammation. So we need to remember that. Okay, this concludes our lecture about the glaucoma and management of glaucoma, clinical pharmacology of glaucoma. Okay, this is an important slide. We need everyone to remember about the group of medication used for glaucoma, such as prostaglandin, beta blocker, carbonic anhydrase, alpha-2 agonist, pilocarpine. Thank you for your watching and have a great day, everyone.